All right, we are live. This is always exciting for me to do these on Fridays or really any day of the week. So I appreciate you joining me today. We're going to have a great conversation just to kind of kick this off, right? We were kind of talking about some house rules that we're going to have with this, in that Bradley and I have only had one conversation so far, which was earlier this week to have a little meet and greet, see what with the Healthcare Advocate Summit coming up, see how we could potentially partner for that. And the conversation went from, hey, this is great, we're really excited, to much deeper, much more collaborative. And we cut it short and said, all right, let's talk live on Friday and get to know each other a little bit better. So Bradley, I appreciate you joining us here on this. So the rules for this, anything goes. We, of course, want to keep positive, and in this challenging part of healthcare that we're in, right? There's no true definition of what makes you a patient advocate, whether you're the patient yourself or whether you're working to help the patient or whether you're the physician. So we'll talk a little bit about those different opposing views, how we don't want to, make anyone else mad or or hurt anyone in this space. We all want to be collaborative and supportive. So everyone should know me by now with Healthcare Advocate Summit. If you don't, it's really nice to meet you. I'm Elizabeth Johnson. I am the Director of Education for the Healthcare Advocate Summit, September 8th through the 10th in Galveston, Texas. I'm also the president of NAMAPA, and that is the presenting sponsor for the Healthcare Advocate Summit. And I also, in my day job, since a lot of us advocates do two things at once, I'm the CEO of Medico. So nice to see, hear, read comments from everyone. So Bradley, I'm going to turn it over to you. Give me some of your background, kind of how you got to where you are now.
All right. Well, like you, I wear a lot of hats. So let me just start out by saying that since 1991, I've been a lawyer, a litigation lawyer. When I got out of law school, I took the first job that I can get because I didn't know what I wanted to do. And it turned out that I would start working for insurance companies. And I was working for insurance companies in court, defending against injury claims. So the example I use is if you get involved in a car accident, for example, you rear end the wrong person, they go to a lawyer, they sue you, you send it into your insurance company. They don't believe it's a merit. The case has merit for whatever reason, usually because of overstated injuries. And my job would be to represent that person through their insurance company. So the insurance company would hire me to defend the case on behalf of the person that probably caused the accident. So that was my gig for about 10 to 15 years. I had my own law firm, and I got really, really skilled at being able to stand up to doctors and nurses and hospitals. And I say that because it's real important to my story. Just the fact that, I was never a doctor. I was not a nurse. But the nature of the legal business that I was in exposed me to all of it. And it made me comfortable knowing my way around the system, knowing who does what, knowing what words to use, knowing what buttons to push. So, fast forward to 2004.
Oh, I think we had a quick delay real fast. So let me ping Bradley and get him back on. Oh, look at that. There we go.
So we'll fast forward to 2004. I wasn't feeling good. It was this beautiful day that I'll never forget. It was early May. It was Mother's Day. Mother's Day fell on my wife's birthday that year. And I end up going to the hospital not feeling good. And it's important to note that when it is Mother's Day and you're the husband and you have kids, you don't go running to the hospital just because you've got a little headache. So what I always try to get across is the fact, number one, I was comfortable dealing with medical professionals. And number two, I was real comfortable in my own body, knowing that just something wasn't right. I've had headaches, but for me to make the decision to call an ambulance and go to the emergency room when I'm supposed to be celebrating Mother's Day. In my mind, it was significant. But when I got to the hospital, it appeared that Mother's Day was also important to a lot of the people that should have been there. And it became apparent that I didn't really have the full-time regular emergency room staff. There was a lot of chit chat going around. I don't recall it being extremely busy, but what I do know is that on that particular day, I was otherwise healthy 37-year-old person that didn't really have any comorbidities or anything of a historical nature that was going to, you know, I just got passed aside. I wasn't triaged appropriately. They wrote me off as maybe, this guy probably went out last night, had a little bit, too much to drink, and he's hungover. And I understand the job of paramedics, and I respect them incredibly, because what they do is they show up and they set you at ease and they get you to talk and everything. And they, how you doing? Blah, blah. And then they sugarcoat it when they drop you off at the emergency room. This guy seems fine. And I think what happened to me is the initial impression that I was just, maybe put them on a little bit of fluids and see what happens. Got relayed and passed down from individual to individual by way of EMRs. My history was the first thing that they saw, and it didn't alarm anybody. So you couple that with the fact that I had what are known as moonlighters, and I didn't know it at the time, but I found out later that the people that actually were there were substituting for the regular staff. There was no real cohesion amongst the people. They didn't really know each other. So everybody stayed within their little compartmental zone, did what they thought was required of them. And when shift changes occurred, not all the, information got passed, but it wasn't anything that was of use or of benefit to anybody. So I ended up getting undiagnosed, failed to get diagnosed with bacterial meningitis. And, looking back, I know that I went into the hospital in time with a headache. I went at about 5:30 in the afternoon. And like I said, through just lack of interest, communication, faux pas, things like that, I did not get the treatment that I deserved. The labs showed that my body was going into septic shock, but the labs never really made it to the right people. One group of nurses and doctors left, the other team came in, and before you know it, 10 hours later, without any antibiotic treatment whatsoever, since we could say anything here, the shit hit the fan, and I was immediately hauled up to the intensive care unit, where finally they paid attention, but they were paying attention because I was dying and I needed to be immediately intubated, sedated, induced. And I stayed that way for a month with, life-saving measures. I went into multi-system organ failure. I suffered from necrosis to the limbs as a result of lack of blood flow from the disease and the vasopressors that were used to treat it. Ended up losing all 4 of my extremities, hands and legs. Did about 6 months as an inpatient in the hospital because, as luck would have it, I contracted every single hospital acquired infection imaginable. So after the meningitis was gone, I was dealing with C. diff and VRE and, even UTIs from, catheters and everything. So I had an extended stay. And, I've always look at it as, hey, that was my time in the joint. And I came out, went back to work as a lawyer, eventually decided that I needed to switch it around. The old defending against the injured people didn't seem like it was going to fly for me too much anymore. I converted my practice and started representing medical malpractice victims, people who had been harmed, everybody wanted to talk to me because I was the lawyer, but I also had been through it. So my phone starts going crazy, and I hear every single phone call from every single, well, not everyone, but the ones that called me, these just aggrieved patients and families who had all these problems with medicine and healthcare, and they don't know who else to call. If their doctor isn't returning their phone call, if they're having a hard time getting, a referral, if they're getting a runaround with insurance, all these things that, happen on a daily basis, nobody knew who to call. And I found out that they were calling me and every other person who said that they were a medical malpractice lawyer, and that wasn't working. So I don't know if you want me to keep going, but I could. I'm talking a lot. So
I got a lot to unpack in that. And I want to go further, right? And I want to push this story because for me personally, and whether it's right to go on the personal side of this, I am. So I was very fortunate to work in an infectious disease clinic. Shout out to Dr. Anastasio and my Emerald Coast infectious disease girls several years ago. And patients that otherwise seem healthy, when they have these things happen to them, it's so different. And burnout is real, right? And it's a holiday, and I'm never going to justify poor patient care. I was taught by my nursing instructors that you treat every patient like they're your mother, brother, sister, close family member. And do we get used to the stuff that comes in? I see this every day. I don't want to say yes, but we kind of do. There's a desensitization that occurs.
Right.
And this is a great reminder that no matter how many times we think we've seen something or how many times we've been exposed to something, you can't just assume that it's not serious. Or I'm not saying jump and get your adrenaline pumping every time, but use those skills, use that triage set, all those things that we've picked up. So first of all, on behalf of nurses, I'm not going to necessarily apologize, but I want to, because no patient should suffer in that manner or be put to the side like that. And especially you had such a unique perspective, right? And have from being a lawyer, working on that side, working with providers. And so I can only imagine like what was racing through your mind as you're sitting there, like, I really don't feel good. Like something's going on. And so knowing how you felt in that moment, knowing that I'm sure there was panic, I'm sure there was frustration, I'm sure there was, fear. When you are working with advocates now, and I'd love for you to kind of go into what Greater National Advocates is, when you're working with them, do those emotions ever come back up for you? Do you kind of tap into that? I'd love to know just what you think there.
I mean, yes, very much so. It's almost to the point where under certain circumstances, it can bring me absolutely right back to that state of mind and the helpless feeling, because okay, I did know, words, and I did know, my way around, way more than the average person, but you realize real quick that you lose every single semblance of power that you thought you had the minute you strip down and are naked in that gown, and everybody else is, looking down at you, and you're just in that weak, vulnerable position. And so I hear that from the people that call me, Yeah. Everybody tells them something different. There's no coordination. When I was in the hospital, I would meet 15 doctors a day, doing rounds, and I didn't know half of them what their role even was. I will be honest and tell you that, I didn't really even know the role of a hospitalist at the time. And I'd been in hospitals before.
And that's a newer thing too. I mean, hospitalists have been around, but it's becoming more of a specialty choice you can almost make.
Right. And it was fairly new at the time. It was evolving, So I don't know that I answered your question, but it does bring me right back, and it almost reinforces what I'm trying to do, which is to solve the problems going against every medical malpractice lawyer out there who makes a living off of filing lawsuits and recovering money. I am absolutely convinced that the better route, at least for me, is to try and get people who are more capable than I was to help coordinate the care before the problems arise in the first place, and to do it with the open arms acceptance of the medical institutions as well. And I think that that is just so important, and it ties in so much to why, you know, you and I connected and immediately decided that we needed to do this again, because, you know, we're coming at this concept of patient advocacy from two completely different angles, but
Yep.
everybody on each side is interested in the same thing. It's just that, you know, we need to work together. And I think the people that are, you know, the advocates on the inside need to understand and respect that there are advocates on the outside, and vice versa. Nobody should be in a position where they're saying, no, I do this better, or I don't need you, or you don't need me. It needs to be a collaborative effort. And, that's why I started Greater National Advocates.
That's fantastic. And I'm glad you kind of mentioned that side thing, right? Like I wish it wasn't the reference we made, right? That was kind of what sparked our conversation the other day. And let's kind of like go down this slippery slope. And something that in starting NAMAPA and the Healthcare Advocate Summit, right? So we've got healthcare advocate, and in the role that I've been in, there's no true like definition. You hear patient advocates all the time. And I kind of want to challenge that, in that I love that patients are standing up for their disease state, or in your case, what has happened to you. You're advocating for better patient care. But I think that healthcare advocates also are patient advocates, in that they're advocating just from the other side, right? It's a collaborative. We're part of a healthcare team. And so I think it takes both sides of it. And, you know, from NAMAPA, we're looking at it a little further up the chain, right? So I want to educate, empower, and reach healthcare advocates and patient advocates with pre-treatment before services are rendered, or on the copay assistance side after services. But how do you prevent that sticker shock from a patient? And so it's all about access, understanding what is insurance, what is copay assistance, what is a prior authorization, all those pieces and parts. And I don't think that really has, I don't know which title to go with. I don't know which way to go.
Yeah, well, I mean, the names they can be confusing, and they get adopted and co-opted, and I think the big thing that we need to address right away is that there's a huge difference between a patient advocate and a patient activist, for example. And we're not that. I mean, we're about solving problems and not just making noise. And the way that there are a few terms that Greater National Advocates could have chosen. We kind of kept it as Greater National Advocates because that includes healthcare advocates and patient advocates and everything. So we're trying to cast kind of like a broad net, bring everybody together. But we settled really on the term, the nomenclature of an independent patient advocate. Some people like the word independent healthcare advocate. Some people like the word private. I frankly didn't like the word private because it kind of eludes some sort of, almost an elite type of a thing. But I think independent demonstrates that they're working for the patient. They don't have an affiliation, with the hospital. And the bottom line is that these advocates are being paid by patients and families. They're not yet being compensated by, any real third parties other than an occasional employee benefit program that happens to cover it. So they are truly independent, and in that they're not being paid by health insurance or the institution, which would kind of create a conflict in the mind of what the independent advocates are trying to do, which doesn't mean that they're going and fighting against everybody. No, they're just working for the patient to try and bring things together the same way that you're trying to do it with the medication and the surprise bills, and even qualifying for clinical trials and things like that. We have advocates all over the country that specialize in that sort of thing. And I'm trying to make it known to the public, same way I see, on this call here, a few of the chat messages coming in. What's the difference between this? What's the difference between that? The system doesn't yet recognize it. And here we are trying to sell it to the public. So kind of in a weird spot right now where, Greater National Advocates is trying to do a couple of things at once. Number one, wake up the nation about the life-saving benefits of independent patient advocacy. And that means letting the public be aware through our advertising, through our website, gnanow.org. That's where you could easily and quickly learn about a patient advocate and find one and find, what their area of specialty is. But at the same time, and I didn't know this going in, there are people who self-identify as patient advocates, but there are probably 10 times more people out there who are patient advocates, who perform patient advocacy services, who have done it for multiple people, most of the time family members, friends, whatever. When they do those sorts of things, they're responsible for everything that you're talking about, that you just mentioned, with the surprise bills and the medical and where's the durable medical equipment? What do you mean I have to, go here for another assessment? Those are things that these people learn that you don't learn in school. You only learn from going through it. So one of the things that I'm really just completely determined is,
I see you getting fired up over this, and I like it.
I don't only want to wait. I know we can wake up the nation to the life-saving benefits of patient advocacy. That's great. We could tell, and we're so equipped to do it. We're ready to go. Mm-hmm. But we've had to pause and hold back and say, well, if we do that, we're going to piss off a lot of the patients and families out there, because I'm calling myself Greater National Advocates, but there's a greater portion of the country where there aren't enough. And I cannot go all out and start saying this is the be all end all, this is going to save lives, if I can't back it up with the help that is needed in rural, underserved areas, and areas that, frankly, are not just populated by low hanging fruit, which is older people. And they're really easy to, it's just easy to find business.
Yeah. And let me make a somewhat borderline controversial statement here, in that if the healthcare system worked, one, I always say I wouldn't be out of a job, because we would find some way to help patients still. But if the healthcare system worked as intended and we were able to go through the process, our patients got what they needed, they got the education they needed, what would be the purpose of an advocate? Right. It'd still be there, right? Because the average person doesn't understand medical terminology, doesn't understand what health insurance is, what those benefits mean. And so I think that, healthcare is not going to work anytime soon. There's my statement.
But, it isn't. And, all the talk, I think we touched on this earlier. I'm trying to do this from the ground up. I start going and talking to hospital administrators. They're going to give me lip service and everything, but nothing's ever going to get done. I want to prove the effectiveness of independent patient advocacies, patient advocates, to the patients who are helped by it. And I want to get to the people on the floor, the charge nurses, the ones that are taking care, the social workers, the discharge people who see the benefit and they say, you know what? I think this person could probably use a little help when they're gone, and, steer them toward an independent patient advocate, because their experience hopefully will demonstrate that these people are helpful and that they're part of the team. So, goals, aspirations, I don't know.
Yeah. And so to answer some questions that we've had kind of come up through the chat, one was, what's the difference between NAMAPA and Greater National Advocates? And there's differences, but there's collaboration. And that's what, kind of is exciting to talk about today on this webinar, is that NAMAPA's angle is to support the advocates, the patient advocates, healthcare advocates, again, whatever we're calling them and however we want to challenge this, provide that education, resource, and support. And Greater National Advocates is embracing that education and support and providing it to their advocates, and then pushing it out so that more patients get help, and connecting to those patient advocates to bring that service. So it's almost like we've created this circle, or this closed group of and I say closed as in anyone's welcome, but Here's your education. Here's your support. Great. Let's go help patients. All right. Patients are being helped. Refer back to more education. And it goes in this, kind of cyclical thing. And I think that, do we know where our partnership and collaboration is going to go tomorrow? No, Bradley, we don't know that. But do we know that we want to work together to better patient advocate lives and patient lives? Absolutely. And so in kind of coming to that education point, I think this is also a challenging part of it is I have a certification. I'm a board certified patient advocate, and I've recently acquired that certification. I'm also a coder. I'm also a prior auth certified specialist, and then I'm an LPN nurse. And so I've got a little bit of everything that I think is relevant to what I do. Does that make me a better patient advocate? Not necessarily. Do I have 10 years of talking to insurance companies, working with patients, exploring their benefits, talking to pharmacies? Yeah. Have I learned a lot by failing? Yes. I've made mistakes. I've had to call back and correct things. And that's humbling, right?
Mm-hmm.
I don't want people to go through some of those same things that I learned on the job. But I think it made me a better advocate. So in my presentation and in my, kind of education that I give back is what were those failures, how to avoid those, and what to look for in the future. But Bradley, in your work with these advocates, is there a standard? What do you need to be an advocate?
Well, advocate, we could look up the definition. I don't know what it says, but I would venture to guess it's somebody that helps somebody that needs help and, can't help themselves. So, and you mentioned certification because there's obviously different levels of patient advocates and different types of, things that they could do. So we spent years finding out what, advocates were calling themselves and what they did. And, it just got so narrow that let's just say aging life care, for example. Okay, by definition, they're advocates. They're advocates for an aging life population. So I believe that aging life care professionals fall under this broad umbrella of patient advocacy for a particular subsect of patients and families. There are also advocates that specialize only in these billing problems and making sure not only that the bills get corrected if there's a mistake, but the proper coding and procedures are, taken care of on the front end so that the mistakes don't happen. There are advocates who are adept and skilled at getting people, who are transitioning out of an acute care facility into a subacute or a long-term care, so be it. And there are advocates out there that are just completely skilled. They've been in the trenches of emergency rooms and they've been ER nurses and they know what to look for. And they're amazing in the time of a crisis if you need it. So, and probably the most important and the overlooked type of advocate is out there is what we were talking about earlier. Somebody that doesn't have any of this experience, but they've taken care of people and they have those skills. And all they need in order to be a patient advocate is using those skills and knowing what their limits are. So one of the things that, I can't make anybody do it, but we strongly encourage it. And you're asking me what the requirements are to be an advocate. In my mind, the requirements to be an advocate is that you are competent in what you hold out yourself out to be competent in. You offer services that are of benefit to people, and you make damn sure that if something is over your head, you are reaching out to somebody that can get the job done. So GNA is not just a place for people who are in need of an advocate to find an advocate. We make it real easy for other advocates to search within our database and find, for example, somebody calls with, let's say, a vascular condition, and they need to find an advocate that has those qualifications. You could search GNA by the nitty gritty according to condition and find hopefully another advocate out there that you might be able to partner with. And advocacy is all about coordination and partnership. Nobody is in it to get rich. Couple are, but
which is the whole reason we're on this chat today, right?
So
is that cooperation part of it. But let me ask lawyer Bradley a question real quick.
Yes.
So because there's no real written compliance or rules around advocacy at this time, what is the best way to I mean, is there a resource? Is there something? I mean, has Greater National Advocates done something with this? I mean, how do we stay compliant? Obviously, there's HIPAA. I'm pretty sure we all know about this.
Right.
CMS has a HIPAA course. If you've never taken it, you can find it on their website. So what do we do? How do we stay compliant? What's your thought?
Well, compliant with what?
Just making sure we follow rules of advocacy, because there really
Okay.
aren't any at this
So,
point.
well, no, there are rules of advocacy.
Okay.
And I will say, and that's what I wanted to clarify. Okay. Um, Before I started Greater National Advocates, I did not do this in a vacuum, and I was not going to just go out there and do it without learning and understanding and completely respecting all the incredible work of these other pioneer organizations that did all this grunt work that allowed me to like capitalize in it and say, oh my God, there's all these great trained advocates out there. Let's get them in the same place and just, my job is to make it easy for people to find them and promote. There are other organizations out there that are really, really good at teaching advocates how to become advocates, setting the rules for advocates. And the BCPA, the board certification, the
Patient advocacy. Yeah.
the patient advocate certification board is a perfect example. They, with in coordination and collaboration with a bunch of other groups, they have adopted, in my opinion, a fantastic code of ethics and rules of professional conduct for patient advocates. In order to be a member of GNA, and we worked this out with the PAC board to make sure that we could do it, because I don't want to exclude people that have these qualifications. I don't want to exclude them if they can't afford to take the test. Maybe they can't even understand, reading the language as well as some. Maybe their skills are different. Maybe they're, they have they have a better way of communicating. But in order to be listed on the site, you do need to subscribe to the advocacy, ethics, and best practices as adopted by the Patient Advocate Certification Board. So those are requirements. We also require that you have some, you have to have either helped somebody or demonstrate experience. But there are certain things that, are real tough. I've one of the things that I've decided at GNA was that I didn't want to be a gatekeeper or a credentialing body or a disciplinary body or anything like that. I believe that the industry is going to have to evolve and grow and govern itself the way any newer industry does. And right now I'm relying on the fact that the people who are listed on the site, I know are dedicated, interested, and they're doing this for the right reasons. And
yeah. So just to kind of clarify, right? There's code of ethics, and obviously the board certified patient advocate exam does talk about compliance, finances, reaching out to others. There's some really great information on there. But as far as like CMS or other commercial payers, there's not really support. There's not really, you can't bill for it all the time, but there's not codes directly saying, hey, you had a third party advocate help you, they can get reimbursed this. I think that's a challenge that you talk about bringing this up and pushing it and, waking up healthcare to, hey, this is a viable option. How do you see that evolving over the next few years?
Well, I see it evolving by way of when advocates do a good job and people see that they do a good job and patients report to their other friends and other people and the word gets spread around, we gain credibility and we gain respect. Mm-hmm. But my overarching vision of how it's going to happen is all based around the payment model, because right now we're in the unfortunate position where what we are asking is people who are in their most down and out dire circumstances. They've gotten to the point where they are obviously reaching outside the healthcare system because something within it has not worked for them. And then we're asking those people to pay for these independent advocacy services. And I need to put an end to that. I want to put an end to that. And I think that in order to start to put an end to it, there needs to be a movement, and that movement needs to come from the advocates themselves, which is why it's so critical for me to make sure that I actually have the entire nation covered with qualified, competent people. Because if we can demonstrate, and if I'm comfortable that there are enough people out there that are doing a good job, I want to use the numbers. I want to almost turn the independent patient advocates into almost kind of like a union. And I want them, and I'll help, but I want to be able to march into employers that are providing assistance programs and say, you need to add this. You need to, because you know what, if somebody that is an employee of your company or one of their family members, if they get sick or if somebody needs to be a caregiver, you can make sure that something bad doesn't happen and that things are taken care of, and that your employee isn't, worrying about doing all these things that they have no idea how to do, reinventing the wheel, like you said, and get them into the hands of somebody that can ease the burden and make things happen. Well, hello, that's just better for everybody's bottom line, yada, yada, yada. But I need to have it, nationwide to be able to take it there. And, it's a big, big undertaking. And it is the absolute next step, which would solve two major problems. Number one, raising awareness and raising it on the awareness, like through the people up through their employers, which are the ones who provide most of the healthcare in this country to begin with. We all know that most of healthcare does come through employers. And if those employers are, and they're all in competition with benefits for employees, and they all have, and if they don't, they're all starting to have these employee assistant programs. I think there's frankly an argument to be made that patient advocacy services are probably covered under a lot of these programs, even though they're not particularly specified or delineated. But the goal is to make sure that they do get to that point right now, and that the people know that they can get it paid for. The advocates know that they can get paid. And at the same time, we're raising awareness and it trickles up instead of trickling down. That's just my vision.
Yeah, because a lot of advocacy, in my experience, is friends and family, right? And actually, I just published an article through NAMAPA that my husband wrote about what it's like being married to an advocate, right? So he never has to worry about what an EOB says or if he needed something, or, our parents, our close family, they call me. I mean, I've helped friends and family friends, and and I love it. That's what I want to do. But you're right. It's got to go beyond that word of mouth and that kind of connection of, okay, I know this person, they've helped one, let's pass it that way. So, coming to the close of our chat here, and I'm telling you, we could probably do this for a couple hours today, because I just have so many questions from your personal experience and all of that. But I think bringing it back to the Healthcare Advocate Summit, right? Talking about taking this to a national level, right? Connecting these people. I'm a big fan of throwing a bunch of people in a room who don't know each other. Mm-hmm. And if my husband's watching, I know he's laughing at this statement because I'm doing it fairly regularly. But that power of networking, that power of learning from other people is just so great. And so the Healthcare Advocate Summit, I mean, that's our foundation. It was started out of necessity because we couldn't find the people that we needed. We couldn't find other advocates. And, it started with one, and then to another person, they became friends, and then a third. And now there's hundreds of advocates I personally have been able to connect with through this. And by coming to one place, and yes, we're watching the COVID situation. We're all very aware of what that is and what that may look like as far as, state rules, things like that. Conversation for later. But coming together, whether it be virtual or in person, and which we're really pushing for that in person, because Bradley, I've loved talking to you on this webinar, but I'd love to sit in a room and just be able to read that emotional, capacity and what's going on. But the Healthcare Advocate Summit is truly a chance for us to come together. And it's not just a conference where we're going to, hype each other up and then all leave. This is such a niche space of healthcare. We're coming together, we're collaborating, and sometimes I say commiserating, because we've all been in that spot where we're tired, we're burnt out, we couldn't figure something out, and we don't want to throw in the towel, but we're faced with options. We're trying to get free drug for a patient. We've exhausted manufacturer resources. We've exhausted grants. What do you do next? How do you communicate to your physician? And I think that us coming together, talking about these things, bonding over the fact that we've tried, we've learned, we've succeeded, we've failed, and going back to our practices, it's going to be like a ripple effect, right?
Yep.
We're going to inspire others. We're going to say, hey, this is a big deal. How do we get ready for the next one? What do we do in between now and then? And so I'm really looking forward to September. I can't wait to meet in person. I can't wait to talk to you, Bradley, further. And I can't wait for the partnership between NAMAPA and Greater National Advocates. And I hope that through the Healthcare Advocate Summit, you are introduced to even more advocates than what you have previously. Yep. So, yeah, I'm just really excited. Any thoughts on that? Any plug you want for September there?
I mean, I can't wait to go out there. My plug is simple. I mean, let's just keep sharing back and forth. We cannot do this without each other. You mentioned it, that it's kind of like, that wheel that I always viewed it as spokes on a wheel, and you have to have all the spokes or the wheel's not going to work. So we're building spokes, and we have two real good, solid spokes on that wheel right here. And, if we can just make sure that we're cross-pollinating each other and making sure that we know what we're doing, you know what we're doing, and that even though we both come from different sides, we're all working for the same exact thing. And that's why I'll say this, in closing, the names and the letters after your name are not what is important to a patient, to be a patient advocate. It's the last thing that somebody looks for when they're calling you for help. They want to know what you can do for them and how you could do it. So we could build on this together and hopefully change the world.
I am looking forward to it. And my bucket list is to end up on Capitol Hill one day and talk about advocacy. So if I go, you're coming with me, right?
I'll be right there with you.
Perfect.
Promise.
Well, thank you, everyone. I've appreciated your time today. Again, we are 40 days out from the Healthcare Advocate Summit in Galveston, Texas, September 8th through the 10th. If you have not checked out our website, healthcareadvocatesummit.com. I'm Elizabeth Johnson from NAMAPA, and I've had Bradley Schwartz here with me, and I've appreciated this time today. Thanks, everyone.
Thank you. Bye-bye. See you in Texas.
All right.